Hi guys, welcome back to Codemaster Coach, your medical coding tutor. In today's video, we are talking about signs and symptoms. And you guys, if I can give you a tidbit, a little bit of information to help you with your coding, the biggest thing that took me a long time to understand is I thought you just give me a diagnosis and I code it. But it's better for a coder to be able to understand the disease process. So as we get into these future chapters, if I bring up a disease process, urinary tract infection, whatever, get you a medical dictionary, go on Google, do whatever you have to better understand what exactly is going on. Because as a coder, not only do we code it, but we need to know whether or not the signs and symptoms that the patient is experiencing need to be coded. For example, what is a sign? What is a symptom? Okay, a sign, let me start with the symptom first, because we as patients go to a doctor for our symptoms. We have a headache, we have nausea and vomiting, we've missed our cycle. Oops, these are our symptoms. And our symptoms to a physician leads to, or there's signs to a physician that lead to a definitive diagnosis. So symptoms to us, and as we tell our physician, he listens to our symptoms, okay. Those are signs to the physician. They're observed by the physician that lead to a definitive diagnosis. Okay, so we understand the difference between a sign and a symptom. Symptom is experienced or observed by the patient. Signs are observed by the physician. Okay, patients seek care for symptoms. Based on those symptoms, the physician determines whether or not those symptoms lead to signs of a disease. So now it's making a little more sense, right? All right, as a coder, I look to see if signs and symptoms lead to a disease process or not. If they lead to a disease process, then I code that disease process and not the signs and symptoms. If I code the signs and symptoms, I'm doing repetitive, redundant coding because I've already captured it in the final diagnoses. Okay? On an inpatient basis, diagnoses described as possible, probable, questionable. You know, the physician will have those sometimes in his diagnoses. At the time of discharge, on an inpatient basis, if at the time of discharge the physician lists probable UTI, possible UTI, or whatever, consider that to be an established diagnosis. For example, a patient is admitted with severe generalized abdominal pain. The physician's diagnostic statement is abdominal pain, probably due to gastroesophageal reflux disease, GERD, which comes to K21.9. Only the gastroesophageal reflux disease is coded as that is the cause of the abdominal pain, and that abdominal pain is integral to that disease process. Okay, words such as probable and possible are not considered to be an established diagnosis for outpatient visits. Okay? If there is not an established diagnosis on an outpatient basis, only the signs and the symptoms are available at the highest level of specificity, and those should be coded. So what are you saying, Coach? Okay, I'm saying if you come into the hospital, you stay 2 or 3 days, and at the end of your stay, your physician says it was probably gastroenteritis. Well, if he suspects that's what it was, he says it was probable, on an inpatient basis, we code it. Because the whole 2 or 3 days you were there, that's what he treated you for. But on an outpatient basis, if you're coming in for that abdominal pain, we don't code probable because he doesn't have time to study it. So all we code on an outpatient basis is the abdominal pain. All right, so when can a sign or a symptom be used as a principal diagnosis? Signs and symptom codes can be found, first of all, they're found in Chapter 18 of your ICD-10-CM code book. So when you get a chance, look at Chapter 18 in your code books and you'll see all of the different signs and symptoms there. There are only a few situations in which a symptom code can be, from Chapter 18, can be correctly designated as the principal diagnoses. Number one, when the diagnostic statement lists the symptom first, followed by two or more contrasting comparative conditions. A symptom code may be assigned as the principal diagnoses, however, if the symptom code is integral to the disease processes that he's coming up with, then you don't code the symptom code. But if they say abdominal pain due to either acute appendicitis or gastroesophageal reflux disease, then you put the abdominal pain, appendicitis, and gastroesophageal reflux disease. But if the abdominal pain is integral to, it's a part of either appendicitis or gastroenteritis, then don't code the abdominal pain, just code the two definitive or questionable comparative contrasting diagnoses. Hope that made sense. So if the symptom is integral to it, you don't code it. You just code the two comparative contrasting diagnoses. Or, number two, when no related condition is identified and the symptom is the reason for the encounter, a code for the sign or symptom is assigned as the principal diagnosis, even though other unrelated diagnoses may be listed. For example, patient is admitted with shortness of breath. An EKG does not provide a conclusive evidence of a cause for the shortness of breath. The patient is also an insulin-dependent diabetic patient, and their blood sugars have to be monitored throughout their stay. So the reason for the admission is still shortness of breath. Therefore, we code the shortness of breath, R06.02, and that's your principal diagnosis because that's what you came in for. And then because the diabetes was treated during that process, then an additional code is also assigned for the diabetes mellitus. Okay? The third opportunity for a sign or a symptom to be your principal diagnoses is when the presenting sign or symptoms is transient and no definitive diagnoses can be made. All they work on is that sign or symptom. They don't ever figure out what's going on, and the only thing they treat is the sign or symptom. In that case, you just code the sign or symptom as your principal diagnoses. The fourth case is when the patient is referred elsewhere for further study or treatment before a diagnosis is made. A lot of times patients will be rushed into emergency room and the patient has these signs or symptoms wrong with them, but by the physician looking at them, he knows this needs a little more in-depth or acute care than what we offer, and they fly them out or helicopter or ambulance them out to another facility. And if all we have are signs or symptoms, then all we can code at our facility are those signs or symptoms. Okay. The fifth opportunity is when a more precise diagnosis cannot be made for any other reason. If there's no other reason, then that's all you've got. Sixth opportunity to make the sign or symptom your principal diagnoses is when the symptom is treated in an outpatient setting without the additional workup required to arrive at a more definitive diagnosis. Because remember, on an outpatient, you go to your doctor with a headache on an outpatient basis, he's treating the headache. However, when they feel it gets severe enough, you've had headaches and it's been going on, and they admit you to the hospital and they do further studies such as CT scans, etc., and they find an aneurysm, then the headache is no longer your principal diagnosis. That aneurysm on an inpatient basis. But on an outpatient basis, is all. If all you have are your signs or symptoms, that's all you can code. The seventh opportunity is when your provisional diagnoses or a sign or a symptom is made for a patient who fails to return for further investigation or care. I've seen where patients have come into the emergency room with pain in one of their lower legs. X-rays are done. They suspect it's either a sprain or a fracture. And today we look at it, we think, okay, it's a sprain. And we diagnose them as a sprained leg. Well, when the patient goes home 3 days later, when the true X-ray comes out, they see that it was actually a fracture. Well, all we had for that stay was a sprain, so a sprain is all that you can code at that time. That's all all you had. Okay? And then the 8th situation is a residual late effect is the reason for the admission. Diagnoses are not designated as principal diagnoses when a related condition has been identified. Let me say that again. A residual late effect is the reason for the admission. And say, for example, your alphabetic index directs the coder to an alternative sequencing, then you follow what your code book tells you to do. So ultimately, your symptom code that leads to the definitive diagnoses are not designated as the principal diagnoses when a related condition has been identified. Okay? The symptom can be the designated principal diagnoses when the patient is admitted for the sole purpose of treating the symptom and no treatment or further evaluation of the underlying disease takes place. For example, when a patient with dehydration secondary to gastroenteritis, they're sometimes admitted to the hospital for the purpose of rehydration because they're so far gone in their gastroenteritis that they're dehydrated now and they don't have the strength to take care of to physically fight the gastroenteritis. Those patients sometimes are brought in for rehydration of their dehydration. Okay? So because the care is directed at the dehydration and not the gastroenteritis, then in this case the code for the dehydration can be designated as your principal diagnosis even though the cause of your dehydration is stated. So understand what I'm saying here? Whatever brings you in. Okay? Outpatient encounters do not ordinarily permit the type of study that the results can be established on an inpatient basis. You don't have enough time to do all those tests and special tests for signs or symptoms. So your highest level of certainty in reporting the reason for the encounter for an outpatient, which often means that a symptom code is assigned as the reason for the encounter. So what happens when signs or symptoms are used as additional diagnoses? Okay, signs and symptom codes are assigned as secondary codes when the sign or symptom is not integral to the underlying condition, unless otherwise instructed by your code book and when its presence makes a difference in the severity of the patient's condition and or care given. For example, many but not all patients with cirrhosis of the liver have what's called ascites, A-S-C-I-T-E-S. When ascites is present, it makes a difference in the care that's given. And so the ascites, which is code R18.8, should be assigned as an additional code. Signs and symptom codes should not be assigned when they are implicit in the diagnoses or when the symptom is included in the condition code. And then what about abnormal findings? As a coder, we must be careful with abnormal findings. When we notice an abnormal finding, whether it's on a chest x-ray, an EKG, or blood work, we must not code those abnormal findings without the physician determining that the code should be generated for those abnormal findings. Because sometimes a more definitive diagnosis of those abnormal findings needs to be established. So when we're reading a chart and we read the blood work shows, elevated BUN and creatinine, that's renal failure. We know this as a coder, we've learned this. Until your physician says it, you don't code it, you do not pick up that abnormal finding. You can query him, send him a little note and says, look at the blood work, elevated BUN and creatinine, or whatever other questions you might have in the patient's diagnoses. And in that case, then you can query your physician, but get him to write something for you. Put it in writing so that when you're questioned, why did you code that? You have something in writing that will be a part of the patient's medical record that says, and what I do is I do a checkbox. Patient's BUN and creatinine are elevated. Check yes if you think I should code the chronic renal failure, or check no if there's a reason behind it, and just don't code it. And and I'll get him to check it, and then I'll leave a signature line for him to sign off on, because I want him to give me permission, because all remember, as coders, we code what the physician diagnoses is wrong with the patient. Okay? All right, as we're moving on, this is lesson volume 5. If you would like a lesson plan with some exercises to code on signs and symptoms, again, it's volume 5. So email me at CodeMasterCoach and request volume 5 if you like the lesson plan with exercises to complete, talking about signs and symptoms. But as we're moving on, and when we get to some of these terms, as you're doing your exercises, you don't know what that disease process is, pull out your medical dictionaries. Google some of these medical terms and try to get a good understanding of what kind of signs and symptoms go with this disease process. Because as coders, we need to be able to distinguish, this patient has this sign or symptom. Oh, but here's the definitive diagnosis, which justifies it. Therefore, if I code this diagnosis, I've captured the reason for those signs and symptoms. We need to try to get into this understanding it, okay? All right, guys, that's it. See you in the next video. Thanks.